Aster Center of Excellence for Cardiac Sciences has something unique, which is team-based, and we call it the Aster Heart Team. Especially that it's embedded in a JCI or Joint Commission internationally accredited hospital. The vision was always clear from day one that we would be a world-class referral hospital. Patients started coming from near and far, and almost all of them are the most complex cardiac procedures one can imagine. The lead performers of our heart team have a couple of very interesting stories.
Having a heart attack is bad enough, but if your heart stops in the process and there is a cardiac arrest, then this is a very dangerous situation. You can lose the patient in 3 minutes. Here we had a patient who had 23 cardiac arrests in an outside hospital, and they were told that patient is sinking. With no hopes, they came over to Aster Medcity, and here in the emergency we saw a patient with very low blood pressure, hardly breathing, on a ventilator, and we had to take some emergency action. The whole heart team swung into action. We explained the difficult situation to the relatives and shifted the patient to the cath lab.
This patient was received by us in the cath lab in a very sick condition. He was on continuous IV medicines to support the circulation, to prevent abnormal rhythms, and he was on a ventilator to support his breathing. We put sheets into his groins, and through which we performed the coronary angiogram, which showed that the most important blood vessel of the heart was damaged or was under risk because of the blood clot which had formed in the coronary artery. This was responsible for all the symptoms and all the problems that the patient was facing. We also inserted a device known as an intra-aortic balloon pump. This helps in supporting the blood pressure, supporting the circulation, and also it helps in preventing arrhythmias from happening, that is to say abnormal rhythms from happening. So in this situation we did primary angioplasty. That is to say, we removed the block that was responsible for the symptoms in lieu of medicines which would dissolve the clot. So we passed a 0.014 inch guide wire under fluoroscopic monitoring across the blood clot. We took a small tube aspiration catheter and sucked out all the blood clots that were responsible for causing the blockages in the blood vessel. Subsequently, we deployed a drug-eluting stent, that is a metallic spring-like device which expands within the coronary artery and supports the coronary artery like a scaffold and helps in the normalization of the blood flow through the coronary artery to reach the muscles of the heart. So with this improved condition, we could shift the patient with satisfactory hemodynamics, satisfactory blood pressure, satisfactory heart rate to the intensive care unit, where he began the long process of convalescence.
Successful angioplasty was just the beginning of a story for him. We had a very sick person who had undergone an angioplasty. He was on multiple medication. He was on 4 medicines to increase his blood pressure. In addition, he was put on a balloon support and was on mechanical ventilation. He was shifted to our ICU, where we have the state-of-the-art technology. We had optimized his medicines on the ICU. He was gradually weaned off his supports and IEBP was removed. He was off the ventilator on the 3rd day. He was shifted out of the ICU after a week's time.
Since this heart function is very low, he is likely to have sudden cardiac arrest due to arrhythmias. Heart attack also produces scar in the heart. Not only it reduces heart function, it also produces scar, like any wound in the body. So from these scars, electrical abnormal circuit starts and they produce malignant arrhythmias which may kill the patient by sudden cardiac arrest. To prevent a sudden cardiac death or an arrest, we put an automated implantable cardioverter device. We implant it on one side of the body, just beneath the clavicle, which will save his patient. They need not go to a hospital to get a shock and revive him. So we placed the device for him. Later, he was followed up in OPD after 2 months. We got to know from the device interrogation that he had several episodes of cardiac arrest, which was revived by the device. We check the machine, and these were all coming from the same point. We have facilities to do a 3D mapping. We make a map of the heart, and from this map we can exactly pinpoint which circuit is causing his problem, and we can take out that circuit by just burning with a radio frequency energy. It is done in a conscious patient. Patient will completely know about it, and it's a painless procedure. It can be done in a one day, and next day patient could be discharged. After that, he never had a shock from the ICD, and he was perfectly fine after that.
Even with such a sick patient, a good outcome was possible only by the involvement of the entire heart team, the anesthesia team, and with backup of good world-class technology.
Here I am narrating the story of a 32-year-old girl who had open heart surgery 3 times in the last 3 months. She had a blocked valve for which she was operated in a reputed hospital in Hyderabad, and she had a repeat surgery following an infection of the heart valve. The repeat surgery was done 1 month after the first surgery, and in spite of the second surgery, her condition deteriorated. She was transferred to our hospital in an air ambulance, and she attended the emergency department, and we took her up for a 3rd time surgery in 3 months' time. It was a very formidable surgery. We explained all the risks, pros and cons of surgery to the patient, and we could repair the defective valve plus infected aorta of the patient.
On one hand, she had already undergone 2 surgeries. She was mentally very depressed. She was racked with infection, what we call as infective endocarditis. And the other major issue that we faced was that her nutrition status was very bad, because 3 months without respite from infection had taken away all her energies. As an anesthesiologist as well as an intensivist, our major challenges were 2. One is in the intraoperative period where we expected massive bleeding to occur. And the second was in the postoperative period to get her off the ventilator and subsequently move her out of the ICU. As expected, she bled a lot in the intraoperative period, and we had to use special drugs like Novo 7, which was very effective in her, and the bleeding could be stopped in time, although she still received a number of transfusions. Once this bleeding stopped, we were able to take her off the ventilator in 3 to 4 days, and then began a Herculean task of encouraging her to move out of bed. We had to use a lot of support, and it was basically a combined effort between the clinicians, the nursing staff, the respiratory therapists. All of us were behind her, and another 2 to 3 weeks we could actually make her move around in the room. She's doing very well now.
This girl is about a 1.5-year-old child. She was known to have this congenital heart disease. She was earlier seen in another hospital, and she was pretty blue, so-called blue baby syndrome. So at that hospital in early childhood they had done some intervention like a balloon valvoplasty. She was better off with that for some time, and then they came to me for the final operation. I had scheduled a surgery for her, but unfortunately she developed another problem, some boil-like thing on the forehead, just at the root of the nose. So that was infected. So I thought it's not proper to operate at that time, because it's a major cardiac surgery, open heart surgery you're going to do. So that had to be operated anyway, this boil. So they came in, that facial-maxillary surgeon along with the neurosurgeon. So without actually correcting the heart surgery, there is some risk involved in this, because with a major heart problem, doing some neurosurgery also can be risky. On the other hand, if I do open heart surgery when in presence of an infected cyst and all that, again the heart valves can get infected. So we had a sort of a dilemma there. So anyway, they went ahead with the operation, and that was successful. But unfortunately, after the surgery, oxygen levels came down quickly, because the heart condition was very serious at that time. So we had all the facilities there. She was in the ICU. So we connected her to the ventilator and stabilized her. The next day, so we took a decision to operate on her, even though there is a risk of other things. And she went through the operation successfully, and she's recovering now. To manage this kind of situations where infection is there, facial-maxillary problems are there, neurosurgeon is to be involved. In presence of uncorrected heart disease, to manage such situations and crashes, we need a multidisciplinary approach. That's fortunately we have in our system, where we have different technicians and technology experts, so that you can bring them together for a successful outcome in a complex situation like this.
Being a pediatric cardiologist, I often see children with structural heart defects. These are children who are born with cardiac problems, and they have frequently many problems like not gaining weight or recurrent chest infections. So I remember an interesting case that came to me a year ago. This was a family whose kid has had heart disease at 6 months of age and was not putting on weight. He was advised surgery, but the family was intensely afraid about an open heart surgery and the implications of what a scar could be on the chest. So they were exploring the possibility of a non-surgical procedure. The child had what is known as an atrial septal defect and was measuring in around 12 to 15 millimeters in a small kid. The child was around 6 to 7 kilos. So I explained to them that cardiac surgery would be probably one of the better options, but since they were insistent, I thought I'll explore the possibility of doing a non-surgical closure of the kid. So after explaining the possibilities that we may have to back out, we decided to go ahead and close the defect using a transcatheter technique. Transcatheter closure of cardiac defects in children is a recent development where by techniques of angioplasty, which we do it in adults, can also be done in children. The procedure was done under general anesthesia. We used a tube to enter into the heart from the right side. We crossed a hole and parked a wire within one of the pulmonary veins. Once the vein was accessed and the wire was parked well, we put in a 8 French tube into the heart and then placed it in the left atrium. Through this tube, we introduced a device which actually sandwiches the whole well. The important thing is that the hole gets properly closed and the edges of the device does not touch into any of these vital structures. This is particularly important in this child because he is very small and the mitral valve could get entrapped in it, or other structures could be pressed upon, and this could have serious consequences when the kid becomes older. We could do this procedure well, and the echo showed that the device was very, very nicely placed, and there was no residual leak from any of the edges of the defect. After the procedure, we could extubate the kid, and we kept the child for another 2 days to see whether things were going well, and the post-op echo also showed things were very good before we could discharge him.
The stories we have heard in the past few minutes gives us a clear vision of the scope of work what the Aster Heart team is capable of doing. It covers such a wide spectrum of clinical complexities and management, but the real story is the people, whether it's the doctors and the support team. That's what makes this a center of excellence.